right, good deal. Well, welcome, Dr. Scher. For you guys who don't know, Dr. Scher is a cardiologist based out of San Diego. He's also intimately involved with the Diet Doctor program. I think you're the main medical, I guess, consultant there. I guess I'm not sure what your exact role is, but I know you kind of do most of the medical stuff there, if that's correct. Can you just give us a quick, 3-minute summary, Bret, of who you are real quick, if you don't mind? Oh, let me unmute you too. That would be much helpful if I unmute you. Give me just a second. Let me unmute. There we go. Yeah.
There we go. I think we got it. Yeah. All right. Thanks. Yeah. So yeah, thanks for having me on. It's a pleasure to be here today. I'm a cardiologist. I've been practicing as a cardiologist for 15 years, board certified cardiologist and lipidologist. But for the past year, I've sort of made the transition to become the medical director at dietdoctor.com and have my own telemedicine preventive cardiology practice. And so basically, my transition really started about 6 years ago when I had this awakening that so many physicians have, that we've been misled about how nutrition affects our health. We've been misled about the importance of dietary cholesterol, dietary saturated fat, how we need carbohydrates, et cetera. And once I had that awakening, it transformed me individually and transformed my practice. And that's why I really appreciate working so much with Diet Doctor right now, because it's the platform to really help hundreds of thousands, if not millions of people learn how we've been misled, learn about the importance of low carb lifestyles for improving your health. And that's how I practice personally and in my medical practice. Yeah, so it's been, that's 15 years summed up in a couple minutes there, but it's been pretty profound how it's changed my life, as I'm sure it's changed yours and so many others.
Yeah, absolutely. And I think it's just, I think a lot of physicians, they get into it with the best intentions, and then you kind of get into the system. And if you do have this sort of an epiphany where you wake up and say, wait a minute, we're on the wrong track. I mean, it's hard to get out of that. And so I applaud anybody that actually has the gall to say, I'm just going to change it and make my own path there. And so are you at this point no longer doing inpatient care, seeing patients in an office? Have you completely distanced yourself from that at this point?
Yes. Yeah. I'm no longer doing that. So I'm out of the hospital completely. I'm out of my general cardiology practice. And so I don't even have a brick and mortar office anymore. I'm doing telemedicine consults, where I have a license. So California, Colorado, Utah, Illinois, Arizona, Ohio, soon to be Texas. So I can do telemedicine consults in those states where we can really focus on preventive cardiology, lifestyle, interpreting labs and tests and exams from a different perspective, right? Because most people are going to get the sort of standard guideline-based care, superficial interpretation that busy doctors have to do. But I'm trying to position myself in a point where I'm not that busy doctor having to rush through tests, but actually be able to spend the time looking through everything more carefully. So that's my medical practice. And then of course, as the medical director at Diet Doctor, really helping guide all the content to make sure it's the most trustworthy and the most helpful for people to reach individuals and to reach, physicians and health coaches and nutritionists to help educate them as well.
Yeah, one of the things, and I've had the pleasure of interviewing a lot of people, over the last few years, a lot of physicians, a lot of cardiologists, and to be honest. And I found when I did my interview with you, I found that you had what I thought was a very balanced, thoughtful, just very sort of, I don't want to say overly cautious, but certainly an approach that was, I think it would be hard to argue with. And I really appreciated that. And I often refer people to the interview I did with you on HBO when we talk about lipids and that sort of thing and that perspective. So I think that's really great that that you're out there, and I think the Diet Doctor folks are in very good hands with you at the helm of as a medical director. So that's really great. Are you?
Yeah, thank you.
I'm just finding. Are you finding that have you had to change much in your positioning, your thought process over the last 5 years, and as things kind of come to the fold? Have you kind of stepped back in one way from when things you thought, or are you kind of saying no, it's even more this direction? Is there any sort of stuff for that? I guess it's really around things like, well, I mean, I guess really could be anything, but I know certainly when we talk about lipidology and the impact of dietary, or the impact of, just serum cholesterol and certainly things around ketogenic diets. What are your current thoughts?
Yeah, I mean, there's so many things in that first question of there are things that I've had to change how I approach or think about it. Absolutely. Whether it's lipids, whether it's blood pressure, whether it's blood sugar, or insulin levels, it's thinking about them as a unit, as a system together, rather than thinking about individual components. Because the way we're taught is internal medicine and cardiology or endocrinology or whatever the field of specialty is, we're taught just to get the numbers down. That's what matters. You get the numbers down. But really, we can focus so much on the one number that we lose the whole picture of the health and what are we actually doing for the patient. And, insurance companies will reimburse you more for having better blood pressure numbers or better LDL numbers or better blood sugar numbers. So there's incentive, there's financial incentive for your medical group or for you as a physician to hit these numbers. So you want to hit them by any means necessary. And that's a completely different scenario than saying, let's improve the health of the patient. One does not equal the other. And I was guilty of this too. You fall into this system where you have your blinders on and you're looking at the numbers, trying to improve the numbers. So that's the biggest thing that's changed. Is like, let's focus on the health of the person. Let's focus on the vitality of the person. And the numbers may play a role in that, but they're not the most important thing in that necessarily. So you asked specifically about lipids. That's, I think, the prime example. The science, the lipidologists aren't making things up to say that LDL is correlated with cardiovascular events for the subset of people that have been studied in most studies, but they're pharma-sponsored studies. They involve people eating low-fat diets or mixed high-fat, high-carb standard American diets. They're disregarding metabolic health in those studies. They don't look at metabolic health. When you equate it for HDL and triglycerides, the correlation tends to go away. So these are the nuances and the parts that most people don't look at because it's not their average patient. Their average patient isn't somebody with great triglyceride to HDL ratio who has completely reversed any metabolic dysfunction and hyperinsulinemia. That's not their average patient. So they don't pay attention. Most doctors aren't going to pay attention to those subsets. Most researchers aren't going to pay attention to those subsets, which leaves us just treating everybody with one blanket recommendation, no matter who you are. And that's not the way to help people improve their health. That's the way to get numbers to look good on a piece of paper, but not the way to get people to improve their health.
Yeah, I mean, I completely agree. I've talked about that many times, and it just seems that we have a myopic focus on LDL cholesterol, and we've had that for, 4 or 5 decades now, and probably, to some extent. Your point is, the average American that walks in the door is metabolically unhealthy. They're inflamed. They are, they have high levels of visceral fat. They're overweight. They have probably pre-diabetes or diabetes in situ or something. And so therefore it makes sense to work on LDL in that particular subset of population, in my view. But I mean, again, we have a completely different cohort, that we're seeing that it may not be the same sort of thing. How do you define, so when you say, let's look at the whole package, what are we looking at? Because I mean, I often tell people, how do you feel? I mean, my goodness. I mean, why do you, people don't come to the doctor because they feel great and say, hey doctor, how do I not feel so great? So how do we define health then? I mean, what are we using?
Yeah, it's a great question. And it's a moving target for sure. But like you said, how you feel is a critical part of that. And that's one of the things with statins, right? Not everybody gets side effects with statins, but if you're one of the people who gets muscle aches and weakness and your doctor says, tough it out because it's helping you, and because of that, you sit on the couch more and you're not exercising, and you're not moving as well, and you're getting depressed, then that drug's not helping you, right? So you have to define, part of how you define health is how you feel and how you're living your life. The lifestyle itself is part of being healthy. But then there is obviously this detailed lab evaluation that we can do that can define health one way or the other. But again, it's not just a standard lipid profile. I like to look at the advanced lipid profile to see the small LDL versus the large LDL, the total size of the LDL, the size of the HDL and the VLDLs, and lipoprotein little a, and then of course the hemoglobin A1C and the blood sugar and the insulin or C-peptide levels. Those are crucial. And then what's your blood pressure, what's your visceral adiposity or your abdominal obesity, your waist circumference. If you can get a DEXA scan or a bod pod or some sort of measure of your body composition, that's important. What's your inflammatory markers? I'm just rattling off a bunch of things, but the point is that it's a much more detailed evaluation than you're going to get in a standard office visit with a doctor who's got 5 or 10 minutes to spend with you. And the other point, though, is there's not one definition of healthy. So someone who has a family history of Alzheimer's disease, where everybody in your family has developed Alzheimer's disease in their 60s, is going to define health and their path to health differently than someone who's everybody in their family has a heart attack at 50 or 60, right? Those might be two different modes of evaluation, two different modes of treatment. So your family history, your personal history, that plays a big role as well for defining what's your right path to health and how do we define health for you.
Yeah, as I kind of, and I'm not a lipidologist, and certainly not a cardiologist, but as I sit back and I watch the sort of the discussion go back and forth, I've seen where the particle size, particle count, it's been kind of variable up and down. At one time, particle size was considered a very strong risk factor, and then all of a sudden people are saying, no, it's just a number, regardless. So where is the data at this point? I mean, what is the current state of lipidology on what's important, what's not? Some of these, I know you talk about advanced lipid profiles. I mean, I know people have talked about LPA, little a, ApoB. What's as of 2020 in May? What is sort of the best information we have?
Yeah, so great question. So let's see if I can go through this systematically. So first is ApoB or LDL particle number are much better predictors of cardiovascular risk than LDL cholesterol. Okay, so the standard lipid profile is going to give you your LDL-C, your LDL cholesterol concentration. That is a poor predictor when compared to an ApoB or an LDL-P, because you want to know the number of particles more than you want to know the total concentration. And one of the reasons why that's important is because of the size and density of the particles will vary out of proportion to the total amount of cholesterol. So we know that those with the small dense LDL cholesterol have a much higher risk for cardiovascular events. Now, part of it is the particle itself is higher risk, and part of it is because that's more associated with insulin resistance, metabolic dysfunction, diabetes, prediabetes. Part of the reason why the lipid community hasn't embraced small dense LDL is because statins don't affect them. PCSK9 inhibitors don't affect them. So if your thought process is, does this person need a drug or not? All you need is the standard lipid profile, because you're not going to see much of a change in your small dense LDL, and so why bother? But if your thought process is, what is everything I can do to make this person healthier, including lifestyle interventions, then all of a sudden the size and density of your LDL is critically important, because that's one of the most important things you see change with lifestyle. So it's not uncommon to have somebody that I put on a low carb diet. Their total LDL or ApoB may go up, but the size and density of that LDL changes dramatically. So you no longer have the small dense LDL, but you have the larger LDL. Now, do we know that larger LDL is no risk at all? No, we don't know that. We don't have data to say it's no risk, but we certainly have plenty of data to say it is significantly lower risk than the small dense LDL. So now this gets into the equation of risk benefit analysis, the overall picture analysis. If you're trading diabetes or prediabetes or metabolic syndrome to get rid of that for a slight increase in your LDL, but a change from the small dense to the larger, less dense, in some situations, in fact, in many situations, that's going to be a overall beneficial change. And that's how studies like the Verta Health study showed that despite the LDL-C, the LDL cholesterol going up by 7 to 10%, the overall cardiovascular risk assessment went down by 12%. So it's not, that they always work in the same direction. So that's why I think when you're talking about lifestyle, when you're talking about a more thorough evaluation, the size and density of your LDL particles are important, and making sure you get an ApoB or LDL particle number. Now, the other part of that is you mentioned lipoprotein(a). So that's also a very important marker for cardiovascular risk. The interesting thing about that is we don't have a drug that easily treats it and improves outcome. So again, people are sort of unclear what to do about it. Of course, there are multi-billion-dollar drugs in development now, which I think is why lipoprotein(a) is starting to get more attention, because the drug companies see something coming on the horizon. But I think its biggest role is just to suggest a higher potential risk, especially for somebody with a family history of cardiovascular disease or someone who still has elevated inflammatory markers. That Lp(a) then plays a bigger role in your cardiovascular risk. And this brings me to another point, if I can keep rambling here for a minute, is that a number of the people who I see in my practice, they kind of want confirmation that they're a hyper responder and they're not at risk and they don't have to worry about anything. Well, lipoprotein(a) is one of the things that I think affects that, because if you have high LDL since going on a low carb diet and your lipoprotein(a) is high, that's a different scenario than if your lipoprotein(a) is low. Same thing if your LDL goes up and you still have a preponderance of the small dense LDL, or you still have high inflammatory markers. That's not the quote unquote true hyper responder. That's someone that still needs a little more attention to make sure the cardiovascular risk isn't somewhere where you don't want it to be, that you still can lower that risk even more. So sorry, getting back to the original question then though, about where do we stand about lipid profile. So, I mean, that's sort of why I think the advanced lipid profile is more important, why lipoprotein(a) is more important, and specific inflammatory markers. So CRP is a general systemic inflammatory marker. That's important and is correlated to cardiovascular risk. There are other sort of more specific markers for lipid inflammation, whether it's an Lp(PLA2 or myeloperoxidase or oxidized LDL. These are all other tests that can get ordered that are a little more specific for lipid inflammation. But again, they don't necessarily change with statin therapy, so they're not recommended for general use, but they can definitely change with dietary changes, especially if you're getting somebody off of a high carb diet onto a lower carb diet. You can see that inflammation come down.
Right. Is there a place that, that has like a composite? I know there's like the MESA calculator, which is, at least has a little more information, particularly if you include the CAC score in there. But is there a current, like, this is an overall risk package, or maybe you have something developed where you can put in all these advanced numbers and say, this is your predicted risk. Now, again, risk does not necessarily indicate disease. And that's one thing that, because we always have to realize that, risk means risk and not necessarily a guaranteed disease type of thing. But is there a place to go where say, this is in 2020, this is the best I can do as far as predicting what my risk might be? Now, obviously, history, if you got history of cardiovascular disease and you've already got a pretty good evidence that you've got the risk profile, but
yeah.
Where do we go?
That's a good question. I wish there was a risk calculator that included the size and density of your LDL and your inflammatory markers. I'm not aware of one that exists. The two main ones that I use that I admit are flawed and very superficial are the American College of Cardiology calculator or the MESA calculator, like you said, because that one at least includes family history and your calcium score, which I think are really important. But I think the key to that is they are just scratching the surface, and that's just the place to get started. A more detailed evaluation, unfortunately, we don't have good numbers to say it changes your risk this way or that by this amount of percentage, because the studies simply don't focus on those factors as much, because they're not affected by drugs, and because that's why they're not generally recommended and not studied as much.
Yeah, we don't see the intent to treat type things with, I don't know, are there intent to treat studies looking at, like, say, lowering hemoglobin A1C and cardiovascular outcomes? I'm sure those have to be out there at least. Are there at least some of those things that have been done? Because that's what you have to do. Ultimately, these long trials to see what happens, so you can actually say this actually has a risk.
Yeah, the problem with the diabetes trials in terms of trying to treat diabetes and reduce cardiovascular risk is that they've been negative. They show the more aggressively you treat diabetes, the more you increase risk of poor outcomes. And you can interpret that two ways. You say, see, it doesn't matter. Reducing your blood sugar doesn't matter. Or you say, well, maybe it's got to do with the treatments. Maybe it's because we're pumping people full of insulin and giving them insulin secretagogues. So we're trying to lower blood sugar, but increasing insulin to do so, which is totally different than lowering blood sugar and lowering insulin at the same time. Completely different physiological effects in the body. So that's the study we need more of. And that's like with these SGLT2 inhibitor drugs, they lower blood sugar without increasing insulin. And they have shown decreased cardiovascular risk, which is very different than looking at people who've been treated with insulin or drugs that increase insulin. So now the endocrinology community is hopefully waking up to this, something that the low carb community has been promoting for years or decades practically, that you can lower blood sugar and lower insulin. And that's where you're going to see the most beneficial effect. But unfortunately, the majority of the data, if you're looking to plug in, percentage benefit, the majority of the data we have is going to say there is no benefit, but that's only because it's the wrong treatment.
I know guys like Jason Fung point out like the Accord trial where basically it was, the same thing you talked about. They aggressively lowered A1C and their endpoint for mortality and cardiovascular disease actually went up relative to the, non-aggressive treatment. And I guess for people that don't know, the SGLT2 inhibitors are basically causing you just to pee out all that glucose. Now, so you kind of inhibit that transporter in the kidney, but one of the negative side effects is these fungal infections of the genitals, which is, perhaps maybe it's better to eat a low carb diet. Perhaps, I don't know. What's your thoughts?
Yeah, it's the same concept. Why do we have to focus so much on getting the carbs out of our system if we can instead just not put them in the system in the first place? I mean, it's too simplistic and it makes too much sense. Just like with those. Gosh, that surgery that was being promoted a couple of years ago, which like a tube in your stomach where you can empty out the stomach, like surgically induced bulimia. The fact that anybody would think could even be a good idea just blows my mind. I mean, that just shows how backwards medicine is, that someone could even dream that up and turn it into a reality. Just shows medicine is backwards for sure.
Well, I mean, we certainly celebrate gastric bypass and, and the different bariatric surgeries. So, I mean, it's kind of similar. At least that was reversible, which is one thing I would say, if you're going to do that, at least it's reversible and you don't end up with, 2/3 of your functioning stomach disappeared. But so let's talk a little bit about the ketogenic diets. How have they evolved over the last few years? How are you guys? Have you guys changed the way you recommend ketogenic diets now versus? And I know you weren't part of Diet Doctor 5 years ago when, I think I've seen some change in the last 5 years. What say you?
Yeah, I mean, I think you can look at it a couple of different ways, but I think one of the big changes is kind of getting away from the concept of all you need to do is eat more fat. Just eat more fat, and that's going to spur weight loss. That's going to, drown everything in olive oil and add as much butter as you can to everything. There's this concept that the most important parts are reducing carbs and adding fat. Well, actually, I think the most important parts are reducing carbs, getting adequate protein, and then using fat as a lever, because you can either burn the fat that you eat or you can burn your own body fat. And so it doesn't necessarily have to be add fat to everything. Now, you can run into trouble if you try and limit your fat, because then you're going to be hungry and then you're just not going to get enough calories. But I think it's a faulty concept to think you can just add more and more fat. So we see a lot of people who are stalled out on their weight loss. And a lot of the times, the first thing you take away are their bulletproof coffees or purposely adding extra fats and oils to everything and instead sticking with the fats that are in the food, and you can see them break through their stalls. I think that's an important concept. Now, when people get started, I think it is important to add lots of fat, because that's contrary to what a lot of people know and believe and have been doing for 20 years. So you need them to sort of get used to adding the fat, and it's really important to fight hunger in the beginning. And adding extra calories can do that. But then as you sort of back off the fat and the calories, as long as you're still getting adequate protein, which is very satiating foods for the most part, and you're still restricting your carbs, then as you back off on the fat, you're going to start burning your own fat stores more. So I think maybe that's the biggest shift, getting away from the concept, just add more fat, and making sure we're getting adequate protein, because, a lot of these trials, these scientific studies look at a diet that's 15% protein. Well, gosh, to me, that is just insufficient protein. And the recent study by David Hall is a great example. It's not even published yet, but it got a lot of attention on Twitter. It was a high carb plant-based diet, 15% protein, versus a low carb animal-based diet, 15% protein. And it was looking at satiety and hunger. And I think that's a setup, a poor setup, because a properly formulated keto diet should be much higher than 15% protein. And especially if you're talking about satiety, because whole foods that contain proteins like meats and chicken and fish and eggs, those are going to be much more satiating and filling than adding extra olive oil or coconut oil or extra butter. Those can have a satiating effect, but not as much as adding the whole foods that are mostly the protein containing foods.
Yeah, I mean, obviously, most of the people in this audience are on animal-based diet, including we've got Dr. Phil Avedi. Here's another fellow. He's a cardiothoracic surgeon in the audience, so he's
Great.
been using ketogenic and then carnivorous diets to lose a bunch of weight and so on and so forth. But yeah, I mean, 15%. You'd be hard pressed to find anybody in here that eats 15% protein. I mean, that's you know, I'd say closer to 30% on most of the folks here, which is probably, in my view, consistent evolutionarily where we kind of grew up as humans. But yeah, I agree. In Kevin Hall's study, I mean, I was very controversial. Obviously, there was people on both sides of it celebrating. You know, the people on the plant-based side say, look, we can eat less food and be satiated. And you know, the people on the animal-based side, well, look, our blood glucose was better, our inflammatory markers were better, our liver fat was better. You know, let's talk a little bit about diabetes and non-alcoholic fatty liver disease and ketogenic diets or low carb diets in general. What has been the success rate with that? What things seem to work? What things don't seem to work with those two conditions?
Yeah, diabetes and fatty liver. So I'll get to that one second. I do need to say, though, I even regret bringing up that Kevin Hall study, because the other thing, it was a 2-week study. So, I mean, come on, let's get realistic. Like, what good is a 2-week study going to do? I mean, that's the biggest fault of anything. So I brought it up as an example, but I even regret doing that because it really doesn't help us much with just a 2-week study. Anyway, so the diabetes and fatty liver. Well, look, no one's done a better job than Virta Health to show how effective ketogenic diets are in treating type 2 diabetes. I mean, if their study results were from a drug, it would be $1 billion drug that you would see promoted in every single doctor's office with posters and pens and pads of paper and handouts with the drug name on it. But it's not a drug. It's a diet, and you know, drug companies and physicians aren't going to make money off of it, so it's not being promoted as much. But I mean, that just shows you the efficacy of using ketogenic diet for type 2 diabetes. And all you have to do is see these examples of, like, Brian Lenskis. You know, Dr. Brian Lenskis talking about how in his entire career he never took anybody off insulin, and then, you know, in 6 months he took 20 people off insulin, or whatever his numbers were when he was talking about that. Like, you don't do that with regular medical therapy. You don't do that with other dietary therapies either. You know, Neil Bernard, the famous vegan physician proponent, he published a study a number of years ago about using a vegan diet to improve type 2 diabetes. And gosh, I forget the exact numbers, but I think the hemoglobin A1C went from like 7.6 to 7.1 or something like that. Like a very small change. And then you look at the Virta Health study where they're actually normalizing the hemoglobin A1C and getting people off their medications at the same time. Not the same study. You can't say it's the same population, whatever, but those two little snapshots show you the difference in efficacy. And in my career, I haven't seen anything as efficacious as a ketogenic diet for improving type 2 diabetes. And then with fatty liver, same thing, and the science is catching up as well. We've published a number of studies on Diet Doctor, reviewing studies that show low carb ketogenic diets improve fatty liver, either by enzymes or even by ultrasound evaluation or MRI evaluation. It shows decreased fat content in the liver. And it's counterintuitive to a lot of people because they hear fatty liver, that means I must not eat fat. Physicians buy into it all the time, and patients buy into it if you hear it from your physician, because it's the way our brains like to think so simplistically. Fat equals fat, therefore I need to avoid fat to reverse my fatty liver. But what we don't realize is there's this concept called de novo lipogenesis, making new fat. And our livers are very good at it, and it does it from sugar, from increased sugar, from fructose, from increased carbohydrates. when your cells are full of glucose and you can't keep pumping out more insulin to tell them to take in more glucose, then your liver is going to start taking it up and converting it to fat in the liver. How do you get rid of that? Get rid of the glucose, get rid of the carbohydrates coming in, get rid of the sugar coming in. Then all of a sudden your body cells are no longer full of this glucose and the sugar, and your liver's not going to take it up as much. So, it actually is fairly simplistic when you think about it from a physiologic standpoint, just not as simplistic as the idea people like to sell that eat fat equals fat, but that's not the case at all.
Yeah, when you mentioned enzymes for diagnosing fatty liver, my understanding is it's not particularly great. I mean, there's something called the fatty liver index, which is basically waist circumference, BMI, triglycerides, and GGT levels. And a lot of people talk to the ALT, AST ratios, and most people with fatty liver may still have normal liver enzymes. Do you find, I mean, it seems like gold standard, obviously biopsy, which no one wants to do. I mean, no one wants to have a liver biopsy if they can avoid it, but imaging seems to be the best way to do this. And then the question I have is, you point to the fact about de novo lipogenesis. I mean, basically the food we eat basically has, basically goes through the portal circulation, to at least the carbohydrate section does. And then it gets converted into fat. And then, but also cannot the carbons from fat that we ingest also be changed by the liver into de novo lipogenesis? I mean, is it an energy oversupply to some degree that can cause that as well?
Yeah, I think that's a great point. Having too many calories, energy oversupply, no matter where they're coming from, can eventually downstream find its way into liver fat. I wouldn't be surprised by that at all. I just think it's, from a glucose standpoint, that and a fructose standpoint, that's where it's much easier to overeat the calories and where it's much more likely to happen. And actually, to address the one thing you said about the liver enzymes, how a lot of people have normal enzymes. I don't know if you remember this or not, but my memory is when I started my training, the high normal of ALT was maybe like 25 or 28 or something like that. And over time, the normal range of the labs have changed. And now like 45 is a normal ALT. Whereas 20, 30 years ago, that would have been grossly abnormal. And they define normal by, taking a subset of 1,000 healthy people and doing the bell-shaped curve and figuring out where everybody lies. My guess is that's why the normal level has been increasing, because people they're measuring aren't normal. They're defined as normal, but likely have underlying insulin resistance and metabolic syndrome and maybe the beginning of fatty liver. So the liver test may be normal, but I would be suspect of any ALT over 30 probably deserves a little bit higher index of suspicion, even if it's still in the normal range. So I think we have to be careful about defining normal. I mean, all you have to say is go to your average airport and look around and see what the normal person looks like, and you realize you don't want to be normal in this society. You want to be optimal or super normal. You want a different set of standards for yourself than what the average normal is.
Yeah, I mean, I would say that just not being sick, is kind of abnormal these days, which is kind of a sad commentary on really sad commentary on the healthcare system in general.
Right, like we just wrote about a paper that came out just a couple of days ago about the NHANES population, this huge U.S. population where they look at lab values and look at different tests and try and crunch things together. Well, what this study did was it looked at people who were healthy. So no pre-diabetes and no diabetes, which you got to give them credit for even defining pre-diabetes. So didn't even have pre-diabetes, but as their HOMA-IR, or their, it's basically a blood value looking at glucose and insulin, as that started to increase, it was still correlated with poor health, with abdominal obesity, with triglyceride and HDL ratio. So it shows that even in people who are defined as healthy, there's still this huge spectrum of insulin resistance and metabolic dysfunction, which just shows how poor we are at making a definition of healthy. It's not just the absence of disease, it's so much more than that. And that's where really medicine has to change and start defining things much more precisely if we're going to help people, especially if medicine wakes up to the impact of a low carb diet for insulin resistance and metabolic dysfunction, because those are exactly the people who need it, who are deemed as being healthy, but actually have evidence of insulin resistance.
Yeah, one of the most frustrating things I find with regard to the quote unquote diet wars is everything almost is always put in the context of weight loss. I mean, we you know, and you know, you've seen studies now that show that independent of weight loss, we see better cardiometabolic numbers on a low carb diet, you know, things like glucose control and inflammatory markers. I saw it all the time in my patients that had, you know, arthritis. Their arthritis pain would go away completely almost before any appreciable weight loss occurred. And my training was, you know, lose the weight, take off the mechanical stress, the pain will get better. But, you know, we were seeing obviously this sort of metabolic effect, you know, independent of weight loss. And I hopefully we can start to frame more of these arguments, say, look at these other factors out there. What are your thoughts on, I know we talked about a little bit about non-alcoholic fatty liver disease, but I mean, visceral fat in general. I mean, we have this concept of ectopic fat. I mean, we see it in the muscle, intracellular, you know, intramyocellular deposits of lipids. So let's talk a little bit about one of the arguments you hear from plant-based camps is saturated fat drives intramyocellular lipid deposition and therefore interferes with insulin signaling, and thus that is the reason for insulin resistance, muscle being the largest, you know, basically glucose sink in our body. What are your thoughts on that argument?
Yeah. I mean, I think it's reaching basically. It depends on how you define insulin resistance, and it also depends on the composition of your diet. So just like you were saying, caloric surplus with fat can still contribute to fatty liver disease. Well, if you're eating a high carb and high fat diet, the way your body metabolizes and utilizes the fat is very different than if you're eating a low carb, high fat diet. They're two completely different scenarios. So the first problem I think they run into is you know, anybody who tries to extrapolate data from a high carb, high fat diet and apply it to the low carb, high fat diet, you're assuming they're the same physiological processes happening, and it's completely different. The way our metabolism works is completely different. So that argument just breaks down from that standpoint to begin with. And then the other things are, you know, there's this concept of insulin resistance even on a low carb diet. But is it insulin resistance, or is it, you know, physiologic adaptation that's actually appropriate? And so defining it in the terms of hyperinsulinemia or not hyperinsulinemia, meaning is your insulin levels high or the insulin levels low, makes a huge difference in terms of your definition of insulin resistance, because insulin resistance with high insulin levels, that's the one we need to avoid, because high insulin levels have downstream effects, whether it's raising your blood pressure and its correlation with cardiovascular disease and cancer and all-cause mortality. That correlation is there. With low insulin levels, completely different physiological effects. So I think the other problem, just besides the mixed diet, the other problem is treating all definitions of quote unquote insulin resistance as the same, where really we need to talk about hyperinsulinemia as the main issue.
Yeah, I mean, we had Ben Bickman on, and I'm sure you know Ben. He obviously does a lot of his research based around insulin resistance. And one of the posits was that, you know, that we hear from the plant-based camp that you know, things like palmitic acid, a saturated fat, you know, in the blood will lead to depositions of ceramides and diacylglycerides in the muscle. But what he points out is that is usually de novo lipogenesis derived saturated fat, which can come from fructose, which could come from, you know, carbohydrate sources, which can come from, you know, energy oversupply sources. So it's not necessarily the dietary saturated fat or the dietary fats, but it is the liver generated, you know, de novo lipogenesis. And again, that comes with a energy oversupply, often in the form of sugary drinks, fructose, you know, maybe high carb, refined carb diets. So I think that's one way to kind of look at it, because he actually did pioneer some of the research which actually suggested that saturated fat could be leading to impaired insulin signaling, but then he realized this was only cell culture and not dietary. You know, dietary saturated fat was not having the same effect on that. You know, as long as it's in the you know, range of normal calorie consumption. Or what's sort of negative?
It's the same. Sorry, it's the same simplistic thinking. If we have fat in our body, it must be because we ate fat, and ignoring the whole metabolic and physiological processes in our body that can that change structures, right? So it's the same simplistic thinking. You're right.
I guess if you ignore the fact that we have a liver that does a lot, that does all that stuff, we can assume that. What sort of negatives are you seeing with people on ketogenic diets or low carb diets? I mean, and how do we address those? Some people talk about thyroid. Thyroid gets tanked. Cortisol levels are spiked. What say you to those sort of criticisms?
Yeah, it's interesting. In some people, you do see changes in thyroid. In theory, there's actually, maybe not in theory, I think it's actually practice, that there's a decreased conversion of T4 to T3. But then the counter theory is the body can become more sensitive to T3, so you don't need as much. So that, I find that honestly to be fairly confusing, because the question again is not exactly what happens to the lab value, but what happens to the person. So I think a lot of the times you can see some lab valuations which may or may not mean anything for the person. And that kind of goes back to lipids as well, right? The downside could be that LDL goes up, but is that really a downside in the whole concept of the patient themselves? The thing that I see is the biggest problem, well, from my standpoint, is when lipids change in ways you don't expect them to. Like, there is a subset of people, I don't completely understand why, who can get an increase in their triglycerides and an increase in the small dense LDL. I think I have certainly a selection bias for that, because those are the people who are going to seek out a lipidologist and familiar with low carb. And so I'm going to see a lot of those people. So I don't think it's a big number, but for those people, I do have a little bit more concern. Otherwise, the risks, the downsides are very, very low. Anything like kidney stones or gallstones can maybe happen more common in the beginning, but then are actually probably less common in the long term. So you can say if that's a problem or not. I guess it depends on your time frame. Other concerns, I guess the other concern is, do you need to be in ketosis? A lot of people want to try and stay in ketosis, and you have to sometimes ask the question, why? They're chasing ketones, they're getting upset if their ketones aren't high enough. And for some people that makes a difference, because you feel better, you notice the difference, your blood markers improve. But for some people, they find there's actually not much of a difference to eating a healthy low carb diet and just not caring if you're in ketosis or not. So from a compliance standpoint and from a health standpoint, it may be better for those people to not worry about ketosis, but still focus on quality of food intake, keeping it low carb, but not worrying so much about ketosis. So that's another issue I see come up over and over again. And again, it gets back to, there's certain general concepts we can all apply. And then beyond those, there's an important part of individualization. So just because ketosis was important and worked for somebody doesn't mean ketosis is important and is going to work for you. But the general concept is whole foods, real foods, low carb, time restricted eating. If you can fit into that parameter and determine whether or not ketosis is important for you, then that's the way to do it.
You touched on time restricted eating. I just want to just kind of delve into that a little more with fasting in general. Are you guys proponents of extended fasting, where people will go 3, 4, 5, 7 days? Is that part of the tool set that you guys utilize? And if you do, is it used in certain select situations?
Yeah, great question. So I think it's really important to break down fasting, because intermittent fasting has become this umbrella term to encompass so many things. Even, a 12-hour on, 12-hour off is considered intermittent fasting now, which I'm not so sure that applies. So I like to say time restricted eating, which is basically anything that's OMAD and less. So basically 24 hours and less is sort of time restricted eating. Then short-term fast can be the 36 hours, the alternate day fasting. Oops, I just got a little message on my computer. Can you still hear me okay?
Yeah, we can hear you even louder.
Okay. All right, good. Something just switched over. Okay. Oh, I think these things died. Okay, yeah, those just died. All right, anyway. Sorry, I lost my train of thought. So any 36 to 42 hours is sort of a short-term fast. And then a longer-term fast is these 3 and 5 day fasts. So I think that time restricted eating is important for pretty much anybody. There may be some small subsets of people who probably need to be concerned about that. But for the most part, time restricted eating should be normal eating pattern, right? Where we went astray is 3 meals a day, 3 snacks, constant grazing, that now all of a sudden time restricted eating seems like a big intervention and a big change, when in reality, it's just getting back to sort of the way we were designed to eat, I think. And so that should be considered normal from my perspective. The longer fasts, which is what you asked about, I think are really interesting. There is data to suggest that they can be beneficial. Now, we can't measure longevity. We don't have studies to show it reduces cancer or reduces Alzheimer's, but there's mechanistic reasons to think that may be the case. But they're also trickier to do. They're harder to do from a compliance standpoint. You have to be careful about medications. You have to be careful about comorbid conditions. So when it comes to something like that, I think it is important to be working with a physician or a coach, a healthcare practitioner, someone who's familiar with fasting, who's familiar with your baseline medical history and your medications, to make sure you can do it safely. But for my personally, not diet doctor, but personally, the clients that I work with, I like to work with them doing a 3 or 5 day fast once a year, twice a year, once a quarter, depending on the person. The other thing is, the concept is you're going to get more benefit the less healthy you are at baseline. So I think that's another thing that the studies seem to suggest. Now, fortunately, most of the people I'm working with are pretty healthy at baseline and already doing time restricted eating and low carb eating. So in theory, you're going to get less benefit necessarily, but I still think you get some benefit. I still think it's important. And even psychologically, it's important, because I can speak from personal experience. I know when I did, first of all, I really hate longer fasts. So I was one of the people who tried the fasting mimicking diet. And psychologically, it just kind of reframed how I think about portion sizes and how much. I already knew our portion sizes were out of control, but once I did the fasting mimicking diet, I was like, wow, this is amazing how much we have normalized these, huge portion sizes. Now, I didn't love the fasting mimicking diet because it's all packaged food and it's all kind of fake food, but it was a good experience, a good experiment for me. And now I've sort of designed my own fasting mimicking diet with real foods that I try to do a couple times a year. But so psychologically it has benefits. And I think physically it definitely does have benefits, but with caution for sure.
Here's another topic that is common: electrolytes. How do you guys deal with electrolytes chronically during transition? Are we eating too much salt, not enough salt? Is salt giving us high blood pressure? What are your thoughts on electrolyte situation?
Yeah, boy, the salt equals high blood pressure is another just complete myth that has been perpetuated for decades in medicine. And I know, because I sang that song for years. I told my patients, you need to avoid salt. And prior to my transformation, I guess you could say 6 years ago or so, it's very common. This is what I was taught. This must be true. But once you sit down and you look at the research, you pull back the curtain, and the emperor's got no clothes, and you realize that there was really pretty baseless recommendations to lower salt for the whole population. Now, I think that good science shows that there's about 25% of the population that is salt sensitive, and that your blood pressure goes up with increased sodium, frequently affecting African Americans, but it can affect anybody. But about 25% of the population is more salt sensitive. The other concept, though, is where's the salt coming from, right? Because in all those prior studies, most of the salt came from junk food. So high salt intake was just a surrogate for more potato chips and more pretzels and more bagged and processed foods. When you look back at the original studies, these DASH studies, that too many doctors misquote as saying it proves salt is dangerous for your blood pressure. If you had a high sodium, low potassium diet, that's when your blood pressure tended to go up. If you had a high sodium, low potassium, blood pressure went up. High sodium, normal or high potassium, there was no rise in your blood pressure, no significant increase in your blood pressure. So a couple of theories. One is the high potassium comes from normal foods, from regular foods. So maybe that was just a surrogate that you weren't eating the junk food, but that your sodium was coming from whole food sources. So it's not the same thing. Or is it that potassium has sort of a counteractive effect?
either way, it completely invalidates the whole concept that everybody needs to pay attention to sodium because sodium is going to raise your blood pressure. So that's the long way of saying, I tell people to salt their foods. I tell people to, as long as you're eating whole foods, real foods, and not the junk foods and the overly processed foods, then sodium is probably not your problem. But if your blood pressure goes up, easily something to measure. If you start developing swelling in your legs, easy something to see, then you need to pay attention, and maybe that means sodium is important to you. But that is far, far the minority and not the majority as medicine tries to promote it. So especially when you're low carb and especially when you're transitioning to low carb, you need to supplement with sodium. Otherwise, you're going to feel terrible. So sodium and magnesium, whether it's adding salt to your food, putting salt in some water or tea and drinking it, or drinking pickle juice or bone broth or whatever the case may be, it's important because ketosis and low carb has a natural diuretic effect where you're going to lose some sodium and you're going to lose some fluid, and you need to replace that. So again, it gets back to this concept of sodium, the dangers of sodium being way overhyped, and not, again, the recommendation isn't the strength of the recommendation isn't backed by the strength of the science. And I think that's very important to try and correlate those two.
Yeah, I think you might have commented on this recently, but there is a recent study coming out looking at ketogenic diets and gut microbiome and gut inflammation. One of the, again, often sort of made arguments is eating a diet that is high fat or even, in my case, a low fiber diet is going to wreak havoc on our gut, our digestive system, our gut microbiome, and we're going to have all kinds of problems. What does the science say, or do we know? Is it just too early to say? What are your thoughts on that?
Yeah, the gut microbiome is a little bit of a wild west. How do we define a healthy gut microbiome? Well, kind of depends on the person, right? There are so many different definitions, and you can look at the hunter-gatherer tribes, you can look at the sort of non-industrialized societies, and they tend to have a broad spectrum in their gut microbiome, a diversity of their gut microbiome. And so that's sort of been extrapolated to anytime you lose that diversity, it's an unhealthy microbiome. Or any time you see a change in certain ratios of different bacteria, it's an unhealthy microbiome. But we don't really have the evidence to say that's an unhealthy microbiome. So I think that's the first problem, is we don't really know what a true healthy and unhealthy microbiome is. Now, the other part that's even worse, though, is how do diets affect the microbiome? So I think maybe a year ago or so, I wrote about a study out of China that said high-fat diets disrupt your microbiome and make them unhealthy. Well, again, it was a high-fat, high-carb diet using soybean oil as their fat, as their main fat, and they showed how it affects the microbiome. That is completely different than this most recent study, just I think last week, that I wrote about, that showed a ketogenic diet, not a high carb, high fat diet, not full of soybean oil, but a real ketogenic diet, how that affects the microbiome is completely different. And they showed that they compared, in this one, a subset was in mice, that a high fat diet that was not ketogenic versus a ketogenic diet affected the microbiome in opposite ways. So it's clear there's so much that we're learning about the microbiome that we really have to take any findings of dietary impact on the microbiome with a grain of salt. Now, the other thing that was pretty cool about the study was they showed the way that a ketogenic diet affected the microbiome was it lowered the amount of bacteria that produce this one type of cell, a Th17 cell, which is involved in an inflammatory response or chronic inflammation. This does not prove that it lowers your inflammation and that is beneficial clinically, but it's one step in the process to say this is something we need to evaluate a little bit more. So I think the reason why I really liked this study is because it shows how misguided we were, or the whole medical community, at interpreting prior studies that high-fat diets are bad for your microbiome. Well, what does that mean? How do we define that? These details really matter. Anytime I see a microbiome study, I sort of roll my eyes and say, okay, we're going to have no idea what this actually means or how it applies to people. But this most recent one kind of pointed that out even more.
Yeah, I think that's a general thing with mechanistic stuff, and that what is it, the T17 cell or whatever. I've never even heard of it before. I was like, well, whatever. It's kind of it's kind of this mechanistic stuff. You're like, well, what does it actually mean clinically? And that's where a lot of people, I mean, we see so much extrapolation from mechanistic facts or studies and saying, well, this obviously means you're going to get cancer and die, when it clearly there's no way you can actually make that extrapolation. So it's very frustrating. And I think you guys echo that, saying that mechanistic data is still weak on the overall scheme of what we use as evidence. Is that correct to say?
Absolutely. Absolutely. Mechanistic data is nothing other than an interesting data point that deserves further evaluation. It is not there to start to make broad sweeping conclusions about how we should live our lives. And I think we definitely get into that danger because, our bodies are really complex, especially when you talk about immune system, inflammatory system. What happens with one cell, who knows how that's going to affect this entire cascade and this entire system. So that definitely, I think, is an issue that far too many people hang their hats on mechanistic studies, when what we really want to know is, what does this mean for me? What does this mean for my body? What does this mean for populations? That's a completely different question.
Yeah, and I'll just point out the World Health Organization's 2015 proclamation used extremely weak epidemiology and mechanistic data to say that red meat causes cancer, and I think that's just bad science. But besides that, one last topic, Bret, if you don't mind, because you kind of touched on this with soybean oil being used as a high-fat diet. There's obviously big proponents of polyunsaturated fats, guys like Walter Willett and others, because of the LDL lowering properties that these sort of compounds have versus, say, saturated fats or animal fats. What are your thoughts on these sort of seed oils? Are they harmful? Are they beneficial? Can we make a conclusion on that yet?
Yeah, it's a great question, and a loaded question for sure. So, and this is part of what we just talked about with the mechanistic studies. Trying to figure out, do they translate to clinical practice? So there are some really concerning mechanistic studies about the polyunsaturated seed oils. I do not use them. I tell my patients not to use them, to focus on whole foods instead. But I have to stop short in saying that clinical studies prove that they are harmful, because epidemiological studies show that people who eat more of them actually do better. But yet, some epidemiological studies show the opposite. Some clinical trials, like the Minnesota Coronary Experiment and the Sydney Diet Heart Study, show that people who had higher polyunsaturated fats actually had a worse outcome. Well, okay, were there trans fats involved in that as well? Could the trans fats have played a role? Yeah, possible. That was definitely part of it as well. So I think we have to be honest with ourselves about the strength of the evidence. Now, is that going to change? The fact that I can't say we have hard quality evidence to say these seed oils are harmful, the fact that I can't say that isn't going to change the fact that I'm not going to eat them. I'm not going to recommend them, because it goes against this concept of eating whole, minimally processed foods as much as possible. It goes against that whole concept, which I think is so important to stick to. And then the other concept is, what are they replacing and where are they coming from? So, seed oils are prevalent in all the packaged foods and the highly processed foods and the junk food and the snack foods and the crackers. So if that's where you're getting it from, that's very different than maybe adding a little safflower oil to make a homemade salad dressing that you drizzle on your salad, as opposed to getting just buckets full of it in your different foods, or cooking with it all the time and exposing it to high heat. So the specifics also make a difference in terms of how you're eating it and how you're taking it in. So, and then also, what's it replacing? If it's replacing real food, if it's replacing butter or coconut oil or avocado oil, then it's probably not doing you a lot of good. If it's replacing, basic carbohydrates, refined carbohydrates, sugar foods, okay, then maybe it's going to be an improvement there, but it still doesn't mean it's the healthiest choice. So there's a lot of questions there, there's a lot of nuances. And I think that's where we can fall into trouble by saying seed oils are good, seed oils are bad, they're healthy, they're not healthy. Things aren't that black and white, but I'm still not using them.
Yeah, I don't use them either. Anyway, Bret, thank you so much. We've gone through an hour. That has been just an hour of wonderful information. Where can people find out if they want to contact you? Obviously the Diet Doctor has got a beautiful website, but as far as if they wanted to sort of meet up with you for a consultation, or where are you on social media type of stuff, so people know how to get a hold of you?
Yeah, thanks. So my website, lowcarbcardiologist.com, is the best way to kind of learn about working with me as a patient. On Twitter, I'm at BScherMD, BSCHERMD. And then at dietdoctor.com is where you're going to find a lot of the content I'm creating. And, we have just so many free resources for people and Diet Doctor that I encourage everybody to check it out to get their information from there. If you see a study that comes out that you're like, I wonder what impact this has, hopefully we've evaluated it and given a more reasonable approach to it at dietdoctor.com as well.
Wonderful. Well, thanks, Bret. Have a great day. Hopefully we'll all get out of luck. I don't want to get into the coronavirus stuff because it's just too polarizing. But anyway, have a wonderful day. Thanks so much for being here, guys. Thanks for coming. I'm going to end this now. We'll put this up on our YouTube channel here in the coming days so people have a chance to watch it. And thanks again.
Thanks, Sean. It's a pleasure being here.
Hopefully I get to see you in person in the near future.
I hope so.
Take care, Bret. Bye-bye.
Bye-bye.